Welcome to APAC, the Asia Primary Angioplasty Congress. This is the first time we're holding the live webinar. So together with me in the studio, I have my great colleagues, co-organizing chair, Dr. Ho Hee Hwa, and also our guest speaker, guest chair, moderator, Dr. Ronald Lee. Okay, I think before we start, I want to have a few house rules that I need to share with you. The most important one is, your active participation and support is actually really important. And I would like to just remind you that you can actually put in your questions in the chat box. Not just the moderators, but we have a, embarrassment of richness of speakers and KOLs joining us today. So they will try and address some of your questions. So I just mentioned, Hee Hwa is with me and Ronald is with me in the studio. But we also have other speakers being invited. Our good friend, Dr. Kwang Sang Lee from United States. Kwang won't be actually joining us live here today, but he did a fantastic case. And he actually made the effort of pre-recorded it and presented the case. So we'll play that later on. But his great colleagues and a good friend joining us today is Dr. Deepak Acharya also from the United States. So he will take the Q&A and actually, dissect the case and see what the learning points are. So without further ado, can I actually hand over to Kaiwa? Maybe you can also introduce the other speakers who are joining us from the rest of Asia Pacific.
Yeah, so this morning we have a fantastic group of experts from Asia Pacific and Australia. So starting from on the left, we have Dr. Sidney Loh from Liverpool Hospital, Australia. We have Dr. Lam Ho from Hong Kong. We have Dr. Nahat Taufik from Yogyakarta, Indonesia. We have our good friend Dr. Azri Ranga from Sedang Hospital, Malaysia. And also Dr. Jose Nicholas Cruz from the Philippines. And lastly, we have Dr. David Huang Wei-chun from Taiwan. And Dr. Huang Wei-chun was our joint course director for APAC Taiwan back in 2019. So the agenda for today's webinar is we're going to have an opening lecture given by Paul and myself. We'll be giving updates on the latest updates on STEMI, Primary PCI, as well as what are the latest insights from the COVID-19 registry. This will be followed by two case presentations touching on two very important topics, multivessel disease in STEMI as well as cardiogenic shock. And lastly, we will have a casual intellectual discussion among our KOLs with good coffee. So I'll now pass over to Paul to start the opening lecture.
Thank you, Kaiwa. Can I have my opening slide, please? Let me see, we're just waiting. Okay. No, not yet. Here we are. Fantastic. Okay. So primary PCI, what's new in 2021? And of course, there is no getting away of mentioning COVID and some of these slides. Kaiwa and I kind of talked about APAC is back. APAC-STEMI is back. And when we thought about it, this is now year 7. We started in 2014 when we have our inaugural meeting. And we were successfully holding it in Singapore and getting a lot of support, not just from the Singapore faculty, but from all our friends in Southeast Asia and also stretching all the way to Europe and America. We ran the course quite successfully for 3 years in Singapore, and then we started to get restless and start moving things around. And in between time, we make a lot of good friends and shared a lot of ideas along the way and learned an awful lot. And we have really strong support and collaboration with Singapore Cardiac Society, with SingLife, and also in APAC from Australia. Just a few slides sharing what the good old days look like. That's how when we started in 2014, we had a full house that time. And then a year later, same venue, 2016. So after 3 years, we managed to get support from the Hong Kong STANS group and Hong Kong College of Cardiology. So the meeting then moved over to Hong Kong, which some of you know is kind of the home country city for me, Dr. Ho, and also Dr. Ronald Lee. So we have friends and supported it. And then after that, we put in effort to move the Congress back to Singapore. And in 2019, we also held it very successfully with the help of Huang Wei-chun in Taipei. While we're discussing management of primary angioplasty, like-minded people get together, and a lot of you helpfully contributed chapters in our handbook, the Primary Angioplasty Handbook, which was published a few years back. The link is put up here. For those of you who are interested in this book, you can actually download this for free in the access sites I listed here. A lot of our discussions in primary angioplasty will be talking about the process, how to get the patient quickly, how to streamline our management to try and treat the patient as fast as possible, putting in the best in arts and the latest technology and knowledge that we have. But we never expected COVID to come around in such a way. It stopped us not just in managing our patient in the usual way, but actually put the whole huge spanner in the system in looking after our STEMI patients. Okay, as I mentioned, there is the process issues and there is the procedure process. We spent a lot of time back then talking about door-to-balloon time. All these were very, very much disturbed in the issues of when the pandemic hit us across the world. But there are patients still coming with STEMI, and we still have to manage and deliver the care that they so deserved. We initially, when we had our Primary Angioplasty Congress, the APAC in 2014, we spent a lot of time talking about door-to-balloon time. But as the time evolves, in 2017, ESC already come up with switching the emphasis, and probably quite correctly, to the total ischemic time. So it's not just how doctors and nurses in hospital can manage patient very quickly when the patient presents to our doorsteps, but actually how to get the patient quickly from the ambulance to the hospital, to the right hospital, and also before that, how to stop the delay in patient seeking help from the first medical contact. So these are things that maybe later on in the meeting, in the webinar, we will touch base on again. But again, no doubt, you can see in this process, across different areas in Asia Pacific or in the world, things have changed a lot. I believe in Malaysia, and Ashley is here, so probably can highlight that. At one stage, they defaulted back to thrombolytics. And in some countries, that seems to be the default mode for quite some time. And in some countries, like in the States and also in Singapore, we actually soldier on and continue to use primary angioplasty as a treatment of choice. When the meeting first started in 2014, these are the typical case presentation we have from some of our fellows. Typically will be a patient coming with STEMI, the access will be a femoral access, and thrombectomy was a routine practice. And back then, bare metal stent was still the treatment of choice. But fast forward a little bit, even during those short period of time when we're having APAC meetings, the guidelines have changed. Okay, transradial approach becomes the 1A evidence of 1A and recommendation. So we are strongly encouraged to do this procedure via the transradial approach. In fact, subsequently, the meta-analysis also showed that TRI was associated with lower all-cause mortality, bleeding risk, and vascular complications. And bleeding being a main driver of lower mortality in the setting of STEMI care. Of course, techniques and skill sets continue to improve, and some of us are now also talking about doing a distal radial approach for primary PCI. But again, we'll be keen to hear the KOLs in the region whether this is being put in practice in your local laboratory. Thrombectomy at one stage was default. Primary angioplasty coming in, sticking the aspiration catheter in and pull out some clot was the default practice. But again, thrombectomy seems to improve myocardial perfusion in STEMI, we now know that there seems to be no mortality benefit, and there is a signal that there may be an increase of risk of CVA if you perform thrombectomy routinely. So the word is routine. thrombus aspiration in primary PCI is now no longer recommended as a routine procedure, and the recommendation is now class 3. But really, on the ground, when you speak to colleagues and friends, and when you speak to people from across the world, thrombectomy is indeed still being carried out. So despite 2 large trials in TASTE and TOTAL, we do know that in large residual thrombus, aspiration a lot of times still need to be considered because the risk of no reflow and distal embolization is still pretty high. Newer techniques and newer devices are now available. One of those are now making the way from America over to this part of the world is the Indigo system. The Cataract RX is a aspiration catheter, a braided aspiration catheter connected to a mechanical pump. So this setup, maintain the suction power much better, and seems to be, from the initial experience in Singapore, seems to work pretty well in large thrombus. We also have come across the stent retriever devices. These are borrowed across from the neurointerventionists when they use a thrombectomy in acute stroke. And we already have some local experience in using stent retriever in treating acute coronary syndromes, especially coronary artery with a large thrombus. And with the APAC connections, we managed to get some like-minded centers to contribute patients and doing a safety and efficacy trial in Singapore, where for the first time, almost all the restructured hospitals are contributing patients to this. The trial is halfway through. We've delayed a little bit because of COVID, but we should be completing the trial, I hope, in 2021 and sharing data with you in 2022. This is the STAT trials that I mentioned about using the stent retriever to remove thrombus in acute coronary patients. So when confronted with large thrombus, this is a slide that Dr. Ho very helpfully put up for me. At that time, I said, don't give up too easily. And these are some of the tips and tricks I shared with some of you during the previous APAC meetings. Okay, try to establish good flow before you stop, and defer the strategies to defer a little bit, run the patient on 2B3A inhibitors or anticoagulation, allow time to actually clear the clot a little bit. Think about, intracoronary lytics, stent retrievers, and also the penumbra cataract system. Coronary stenting in primary PCI seems to be now the default, isn't it? Meta-analysis of 7 trials showed similar mortality benefits compared to bare metal stent, but if you use DES, the chances of getting TLR are significantly lowered. Nothing new here. Comfortable AMI and examination also, established the role of bioalignment stents and other DES in the use of AMI here. And for ESE in 2017, it gave a class 1 indication of the use of DES over bare metal stents. So, again, there seems to be a practice shift away from bare metal stents into DES, and the risk of bleeding again seems to be highlighted and seems to be addressed by them. But is it really true that all DES the same? Comfortable AMI talk about bioalignment stents, but that's a stainless steel platform. Would it make a difference to your STEMI patients? Here, I want to highlight some of the more recent studies looking at the more contemporary stents in use in your STEMI care patients. And I highlighted the paper published recently looking at the use of the ultra-thin strut stents in the STEMI group of patients, the BioSTEMI study. And in this trial, they look at the Osiro stents compared with the incumbent, a lot of us saying, the incumbent everolimus eluting stent science, and look at a large trial, randomized trial. And unlike a lot of recent trials, this is not a non-inferiority trial. It's powered for superiority studies. And there you can see that the use of ultra-thin strut stents like the Osiro seems to give you a benefit in terms of target lesion failure compared to science stents over a 2 years period. So why is it the case? Then, it's obvious that, the stent strut is thicker, There is less endothelium to cover the stent in terms of healing process. 60 microns compared with some of the stent, which is 80 to 90 micron in strut thickness. So there's certainly an element of a thin strut stents being beneficial. And of course, don't forget, the biopolymer is also biodegradable here. So at 2 years follow-up, I mentioned early on in terms of the target lesion failure, seems that using this ultra thin strut stents is certainly beneficial compared with others. But stenting or not, I spent time talking about bare metal stent, drug-eluting stent, but still putting a stent in, there is an intrinsic rate of 1 to 3% risk of stent thrombosis over a period of time. That may be because, during primary angioplasty, you don't have time to assess the patient properly. It may not be able to assess all the bleeding risk and the drug allergy risk and metal risk as such. So is that possible, maybe not putting a stent in and still can treat primary angioplasty patients? Is it even feasible for that? So at this point, I might just hand over to my co-chair, Dr. Ho. He probably would have more experience of using drug-coated balloons in primary angioplasty than most of us in Asia. So over to you, Kewa.
Okay, thanks, Paul. So I think Paul has given a very nice overview on the latest therapy for the management of primary PCI. And we're coming to the topic of, is it feasible to use drug-coated balloon in primary PCI? I think stenting should be the standard of care, but as we all know, sometimes it may not be the most appropriate therapy for our patients. And do note that there is quite a slightly increased risk of stent thrombosis. So if you look at the old clinical trials like the PAMI trial, Cath Lab, where they evaluate the use of POBA versus bare metal stent, the only difference is in terms of TLR, and there was actually no mortality benefit. So if we can use drug-coated balloon effectively in primary PCI to reduce the rate of TLR, perhaps this may be an appropriate therapy for some of our patients. So there has been a recent randomized controlled trial to evaluate the use of drug-coated balloons versus drug-eluting stent in the setting of primary PCI. And the name of this trial is called the Revelation, and it was published in JACC Intervention in May 2019. So if you look at the trial, number of patients is about 120, about 60 patients to both arms. And it's quite a contemporary trial. You can see that the transradial approach is very close to 98%. And as we all know, when we do drug-coated balloon, lesion preparation is extremely important. But in the setting of primary PCI, you have the presence of clot. So thrombosuction is very important when you plan to do drug-coated balloon angioplasty in primary PCI. So you can see that the rate of thrombosuction is about 80% in both arms. The reason is because you want to clear the clot, and then you want to deliver your drug using the drug-coated balloon. So lesion preparation is important. So we do thrombosuction if there's a presence of significant clot. This is followed by pre-dilatation. You can see that it is about 100% in the DCB arm. And if you have achieved optimal angiographic results after your lesion prep, then the final step is to use the drug-coated balloon. So in the Revelation trial, they actually use the Pantera Lux drug-coated balloon. And you can see that the bailout stenting is about 18%. And when it comes to the outcomes at 9 months, interestingly, they use FFR as the primary endpoint. And the FFR was 0.92, which is above the, showing that the artery is non-flow limiting for both arms. And if you look at the hard clinical endpoints, again, very low MACE rates. So what the Revelation study shows is that in selected group of patients, DCB strategy was non-inferior to drug-eluting stents in terms of FFR as well as clinical endpoints. So this is a safe and a feasible strategy. So the key points is we have to select our patients carefully. Again, we have to do the adequate lesion preparation. In Asia, we have a lot of patients who have diabetes with small vessels. So some of these patients may be suitable, and we can use them in de novo lesions. In patients who present with very late stent thrombosis, rather than adding in another extra layer of stents, perhaps drug-coated balloon is a good strategy. And the beauty of drug-coated balloon is you leave nothing behind. So we're going to cover two important topics during the webinar. One is the multi-vessel during primary PCI. So this will be covered by Dr. Sidney Loh. And the second topic that is also important is cardiogenic shock. And we have Dr. Lee, Kwan Lee, as well as Dr. Deepak, who is going to give us insights on the latest updates on cardiogenic shock. So coming to 2021, how do we practice our primary PCI? I think right now, radial access will be the default strategy. We no longer perform routine thrombus aspiration. We may perform it for patients with large thrombus burden. And I think the choice of therapy will be either drug-eluting stent or it could be drug-coated balloon. So we all know that COVID-19 has affected our lives, and it certainly has affected the STEMI, our STEMI patients, as well as our healthcare system. So the COVID-19, if you look at the global trends, there seems to be a decrease in STEMI activations. The range can be 20 to 50% during the peak pandemic. And what they found is that possibly STEMI patients may have worse outcomes because they have delayed presentation. There seems to be a system delay. A lot of hospitals report a more prolonged door-to-balloon time, as well as there is a delay in management. And there's also the reason for decrease in hospitalization is because of patients' fear factor. They are afraid to come to the hospital and get infected. And there's also the distribution of healthcare resources, because some hospitals turn into a COVID hospital and they had to shut down certain services. So this is a chart showing you the Kaiser North American California State incidence of AMI. If you look at the red line, that is the incidence of acute MI in 2020. And it is much lower than the incidence in 2019 in the same period of time. And it associates very well, as you can see from the blue line. You have increased hospitalization for COVID-19. The incidence of AMI reduces inversely. So when the COVID-19 pandemic first started, there was a lot of controversy on how should we treat patients with STEMI. I think at the beginning, a lot of people advocate to use thrombolytic because they felt that it is safer for the healthcare providers. But I think increasingly the evidence, as well as some recommendations by the ACC, SCI, as well as AHA, they mentioned that primary PCI should still be the mainstay. Why is it preferred over lytic? Because they found that not all the STEMI patients have obstructive CAD on coronary angiography. There's a lot of STEMI mimics. For example, a patient may have menocarditis, myocarditis, and stress-induced cardiomyopathy. And we know that in elderly patients, if you give thrombolytic, there is an increased risk of intracerebral hemorrhage. So while we try to perform primary PCI, at the same time, we also have to protect ourselves. I think right now, I think all of us are working in the lab using the full PPE. A lot of us have to change our workflow. We have to designate a lab where to handle all the confirmed as well as the suspected cases. So some of us turn our lab into a negative pressure Cath Lab, or some of us added in the HEPA filter to facilitate the gas exchange. And a lot of times we will have a low threshold to intubate the unstable patients. So this is the PPE, which is the current norm for most of us right now. I think we all, for those of us who wear PPE, we know that it is not easy to operate a patient using full PPE. Some of us complain of fogging, some of us complain of heat, some of us complain of migraine. So, but it is something that we have been struggling with. So when patients with STEMI and COVID-19, we know that they do badly. And do we have the data on their outcomes? So in Singapore, we treated a lot of patients with suspected COVID-19 with STEMI, and majority of them turned out to be negative. So we only treated a handful of patients with STEMI and COVID positive. So do we have any idea on the outcomes of these patients? So there are two big registries, one from Europe and USA, that gave us some insights on the clinical characteristics and the outcomes for this patient. So this is the Spanish registry, where they look into close to 1,000 patients with STEMI as well as COVID-19. As you can see, those have with confirmed COVID-19 positive, they have bad outcomes. They have a high incidence of heart failure, high incidence of stent thrombosis, higher incidence of cardiogenic shock. And importantly, the mortality as well as cardiovascular mortality was much higher. And we look at the North American COVID-19 MI registry. Again, they look at 1,000 patients and they divided into three groups. So the first group is the COVID positive patients. The second group is what we call patient under investigation. So these are the patients who are suspected to have COVID, but subsequently tested negative, and they have a control arm, about 460 patients. So what they found in the NACMI registry was that majority of patients were the non-white patients. So a lot were the Hispanics or Spanish patients presenting with both AMI and COVID-19. And the patients tend to have atypical symptoms. A lot of times they have shortness of breath, they have abnormal chest X-ray showing pulmonary infiltrates. And when you look at the clinical outcomes, actually the mortality is at least 30%. So 1 in 3 patients do not make it out of hospital. And primary PCI was feasible. They managed to achieve door-to-balloon time below 90 minutes in more than 70% of the time. And about 180 patients underwent coronary angiography, and what they found is that only 70% require primary PCI. And predictors of death are patients who require intubation, who had cardiogenic shock before PCI, in-house presentation of STEMI, diabetic, as well as older age. So the other thing that is important is that, patients are presenting late to the hospital, and it's important to get a proper history. And this is one of the patients that we saw that, presented 4 days after his onset of chest pain. And you can see that he had a myocardial rupture over the posterior wall, and we had to send him for a patch surgery, and he survived. So something that is very important to look out for. So my take-home message is that primary PCI saves lives. I think without a doubt, if you perform primary PCI in a timely fashion, patient will survive. And as we have heard, we need a very good system of care as well as a very efficient procedure. I think COVID-19 has affected our healthcare system, but I think we need to adapt, change, and be resilient during this difficult period of time. So this is my last slide, just showing you 2 pictures I took recently from Garden by the Bay. Is a glass exhibition by a very famous American sculpture called Dale Chihuly. On the left, you can see is the rising sun, which represents daytime. And on the right is the moon, signifying the nighttime. And we know that STEMI patients present at any hour of the day, and we have to strive our best to treat them and achieve the best outcomes. Thank you very much for your kind attention.
Thank you very much, Paul and Hee-Hwa, for the very comprehensive and also forward-looking lectures on STEMI intervention, especially in this era of everyone is battling against the COVID-19 virus. Well, later on, moving forward, we are going to have a next presentation from Dr. Sidney Low on a very contemporary and also to some extent debatable topic of how do we deal with multivessel coronary artery disease in patients who presented with STEMI. And this is particularly timely in view of the recent publications of the for our AMI trial that was released recently in the New England Journal of Medicine. So for Sidney, Sidney is no stranger to anyone who are either interested in or involved in the PCI. Dr. Low is a Cath Lab director of the Liverpool Hospital in Australia, as very senior interventional cardiologist with super competency and expertise in numerous areas, including acute coronary care, chronic total occlusion, device, and vascular access, antiplatelet therapy, etc., etc. And we see Dr. Low all the time in all the interventional cardiology meeting. He either participate as a director, as a course organizer, as well as faculty members as well. So today we are privileged to have Dr. Low to talk to us on this topic of multi-vessel PCI in patient presenting with STEMI. Dr. Low, please.
Hello. Thank you very much for the invitation. And it's my pleasure to join you. Can I have my slides? I can't see them at all. Thank you very much. Look, APAC is one of my favorite meetings. I'm glad we're still running it, and I really enjoyed the first talk. And thank you, Paul and KY, for organizing this. And Ronald, thank you for the very kind introduction. So my pleasure is to speak about multi-vessel disease and STEMI. Will flower MI study impact my practice? My disclosures are that I am on the Abbott advisory board. Now, multi-vessel disease is common. In fact, half of the STEMI patients in the Eurotransfer registry had multi-vessel disease. And in fact, in common, frequent in clinical practice, incomplete revascularization of other potential lesions in a coronary artery set is well seen in the Syntax randomized trial for PCI. In the PCI arm, 43% were incompletely revascularized, 60% in the acuity study, and in clinical practice in the real-world New York STEMI registry, 78% were not fully revascularized. Well, is there a problem with not fixing the other arteries? And there are many reasons why we don't do everything, particularly in a first procedure. In fact, the guidelines are recommended not to do that for some time prior to 2012. And as you know, that PRAMI and culprit really set the stage for a single procedure during STEMI and fixing all visible other lesions in a randomized sense. However, they have exclusions. They were fairly small, and there was an immediate procedure with no FFR guidance. In the Dynami Premulti and Compare Acute, FFR was done. And you see that there's a stage procedure. And in fact, in Compare Acute, 80% was fairly immediate and 20% was staged. But there were much bigger trials, but still sub 1,000 patients. And it demonstrated, as you can see the hazard ratios, a benefit for reduction in combined cardiovascular events. The guidelines did change then around 2017. You see the European guidelines changed from a red, a class 3 indication, to class 2A based on these studies. And in 2015, the US guidelines, you can see PCI of a non-infarct artery may be performed in selected patients STEMI with multi-vessel disease when they're actually clinically hemodynamically stable or as a planned procedure. You see, the level of evidence is not very high. And in the Australian guidelines on the left, it was reasonable, although the data was said to be fairly small observational numbers. Now, I thank some of the, I can't see my slide deck, I'm sorry. I thank Dr. Sonia Burgess, who did a PhD with us looking at complete revascularization in STEMI, and you can see that she's published some papers, and you can see the curve separations. This is a way of describing what we leave behind. This is the residual syntax score based on a syntax trial, and of course the cutoff is around 8. If you leave anything more than 8 in terms of what you don't treat, then perhaps you're leaving too much potential ischemic territory unrevascularized, and it's associated with poorer outcome long term. Now, we know that angiography we've used and we're still using because we're very comfortable. And what is in the number? And of course, you can see here the really classic paper now is 11 years old. At a number of 70% or more diameter stenosis, the probability of having an FFR less than 0.8 is fairly high, 80 to 96%. I think no one argues if a stenosis is 90% stenosis, it is going to be tight. And regardless of the vasospasm in a non-culprit vessel being relieved sometime after a STEMI, when it's the acuteness of the procedure is being, they're healing, the FFR, you can see that is a little bit debatable, and there's a significant population that you will not be ischemic when you're hitting the 50 to 70% range in diamond stenosis. You can see that 35%, maybe a 35% in this paper, will be FFR positive for ischemia. I'll show you a very quick case. 51-year-old man, and this was done in 2013 with an anterior STEMI with shock. He's diabetic, he's a smoker, hypertensive, hypercholesterolemic. You can see the LED is occluded, and at the same time, there's proximal circumflex disease, there is OM1 disease, and there's proximal right coronary artery disease. The LED was revascularized. After revascularization with a bare metal stent, 30 by 18 balloon pump was placed. Heart team discussion occurred some days later, and you can see a lesion in the mid-LED at a diagonal. Now, on follow-up, the patient actually took a while. 3 months follow-up, you can see a patient has not had bypass surgery, and the lesion looks better. So the resolution of some of the vasospasm you might see during acute cases. The FFR on this occasion is 0.88, suggesting no ischemia, although we can debate about the reason. It may be that the anterior wall may be infarcted, IMR may be very high. BMS, because of that, LED does not need revascularization in a diabetic. The subsequently stenting of 2 other vessels were done with bare metal stent in the right coronary artery of the size 3 by 18 at 2.25 in a proximal circumflex. And you can see that it was such a stent jailed, and no attempt was made to fix the OM branch. And that led to a residual syntax score after revascularization here of 3 vessels, about 5, less than 8. Well validated by the data, because 7 years later, the patient's still alive. You notice that there is a biventricular lead, a left ventricular venous lead there with a defibrillator lead. And this is an angiogram done in 2020, just last year, and 7 years out from his anterior STEMI in shock. This is the LAD lesion, and this is the right coronary artery. The stents remain patent, and he has no further TLR. So, of course, in 2019, we have the largest randomized trial, which is the complete trial. You can see 4,041 patients. We're looking at the feasibility of complete revascularization no later than 45 days post-primary PCI or randomization. The FFA guidance was necessary only if your non-culprit lesion was between 50 and 69%. Will require an FFR less than 8.8 to proceed. You are allowed to proceed if the lesion is visual leads estimated at 70% diameter stenosis or more. And you noted the FFR guided PCI was only 0.8, less than 1% of the entire population. So not a lot of FFR was actually done. You can see that the 2 co-primary endpoints are cardiovascular death or new MI, and driven largely by non-fatal new myocardial infarction, about 26% reduction. Number needed to treat was 37. And if you add ischemia-driven revascularization, you can see it's 49%, a little bit more benefit, and less numbers to treat, about 13, to derive benefit. And this is sort of the curve you would see, highly significant result. Seems a good thing to do. There was no randomization of the timing of the non-culprit PCI. About 4%, 3.9% was offered complete revascularization after 34 days or later, but 84% completed revas within 3 weeks. The total numbers of complete revas is about 90%, and this led to a residual syntax of 0. And 68% had incomplete inpatients completed revascularization with a median of only 1 day, so they actually just came back to lab the next day. Now, this led to a meta-analysis, and 3 of them actually, and they all show pretty much the same thing. You can see that the point estimate is left of the line, and this is for cardiovascular death. And so these are highly significant meta-analyses, and they basically all show, you do the meta-analysis of this data set, and we can see some of the trials were not powered for cardiovascular death, but overall, a meta-analysis demonstrated that these will derive a cardiovascular mortality benefit for complete revascularization in multivessel disease after presenting with STEMI. We can complain about randomized controlled clinical trials. Sometimes is driven mostly by revascularization prior to complete anyway. And of course, patients, we didn't examine the staging and was not randomized. In complete, sometimes you can say that maybe they're relatively low risk patients. Residual syntax may be only 7. And you can see the non-culprit PCI index could be called culprit only. In fact, there's crossover either way, about 4%. So some who are only culprit only had non-culprit PCI as well. A few patients were staged at more than 1 month. And of course, is this real world? There are a lot of reasons why we, in a very idealized populations, randomized in clinical trials, perhaps not a reflection. And of course, there's concern about revas in things like CT-PCI when you can actually harm patients if you do it badly. And of course, the FFR was not mandated in this trial. Let's look at briefly some special considerations, one of which is diabetes. And diabetes in the STEMI patients are much more likely to show multivessel disease. And in this is our data set over 10 years at Liverpool, and you can see it's a 12% absolute difference compared to non-diabetics in terms of the frequency of multivessel disease in the STEMI. And of course, the cardiovascular death rates are substantially higher in diabetics if they're diabetic. Our data is set significantly, 14% versus only 9%, almost doubling. And the difference in the rates of cardiovascular death between diabetic and non-diabetic patients, you can see this evidence is very early amongst the curves, and it follows up even after 10 years, it persists. It's a much higher risk cohort of patients. Women, we found that women in our data set over 10 years, if you leave compared to men left with a residual syntax of more than 8, have double the risk compared to men of cardiovascular death or MI post-STEMI, and 3 times the risk of cardiovascular death alone. It's published in American Journal of Cardiology. Well, I'm a CTO operator, and the thing is that people have looked into this and looked at treatability of all lesions. And interestingly, for patients left with a residual syntax of more than 8, which is significant territory, 98% was only at least one treatable lesion was found. And 90 of these untreatable patients, right? 90% approachable without having to stent a CTO lesion or left main to get a residual syntax below 8 as a result, as an aim of more complete revascularization. 10% had residual syntax scores of more than 22 in these studies that are referenced. And of course, there are at least 6% or 10% in clinical practice of comorbidities such as dementia, frailty, set bleeding, that maybe makes the patient less appropriate to be further revascularized, or perhaps CTOs, which are not approachable. In terms of CTO lesions, this is much more frequent in this population, maybe 7 times more frequent that are untreated. And then they're attached to an increased risk of death, 20%, increased risk of MACE, maybe 1 in 2, 53%. And of course, all the untreated major CTO epicardial coronary arteries had a reduced syntax score of more than 8, suggesting there's significant territory subscribed by them. And a lot of them, 2/3 of them, are fairly approachable by non-CTO operators because their JCTO scores 0 to 1. And the difficult ones are about 1/3, which, of course, if you're a dedicated CTO operator, will still achieve high success rates. And in culprit shock, we know that doing non-culprits may not be a good idea because it might also lead to increased risk of renal replacement therapy, and it still remains a little debatable and controversial despite the randomized trial. In flower MI, this is one of the topics of this talk. This is a recently published New England Journal paper, and as you know, was presented here in ACC 2021. It is a French study, as you know, is randomized 1-to-1, and you need a non-culprit lesion of 50% or more in diameter stenosis. And you can see the follow-up after discharge, 1, 6, 12, and 36 months. And the composite endpoint, all-cause mortality, non-fatal MI, unplanned revascularization, urgent revas at 1 year. There are exclusions. Shocks excluded, and this is the next talk we're going to hear. Previous bypass surgery, very tortuous calcified or CTO lesions. Of course, single vessels are outed. 1,171 patients, 590 versus 581, 1 year follow-up. This is the published paper. Mean age 63 years. Females are 15%, about 18% diabetics, and 97% had staged non-culprit lesion PCI. 66% FFR guided and 97% angio guided. Now, I'll just point you to the number of double vessel and triple vessel disease. Only about 20 to 25% were triple vessel. These are fairly preserved LV function. You can see EF is around 50%, and 96% are staged. FFR prior to the PCI is 0.79, and FFR post-procedure 0.91. And of course, lesions with FFR less than or equal to 0.8 was only 55.7%. And you can see that the non-culprit stenoses on the right-hand side bottom, that there are a significant proportion of people with the 50 to 69%, 42%, which is in contrast distinction to complete trial, where the vast majority of people had 7% or more and did not require FFR to prove that they were ischemic. This is, unfortunately, of course, is not a positive trial. So therefore, FFR-guided PCI is not superior to angiographic-guided PCI. In fact, the confidence interval potentially can suggest a 23% superior, 123% inferior, with an increased risk of non-significant myocardial infarction by 77% in the FFR group. So it may actually be a lot worse. And accompanied with the time required and the costings involved with a pressure wire in a non-culprit vessel, there's no conclusion in there for this as a strategy moving forward. And you can see the primary endpoint was 30% higher in the FFR guided group. So the event rates overall were fairly low in the trial in both arms, but the investigator's preference then is stage angioplasty for the non-culprit. But FFR guided PCI does not reduce the risk of the composite endpoint. In fact, of course, there's no cost effectiveness favors the angiogram in this study. I'll show you a brief case to finish off, and largely related. This is a recent case, 66-year-old man with inferior STEMI, heavy smoker, intubated because he had a lot of VT, and in fact needed 39 defibrillations consistently, almost kept recurring despite medications. Had heart block, so a temporary wire was put in, as well as overdrive pacing was attempted. LED was also occluded. This is the right coronary artery. You can see the pacing wire. This is right coronary artery after stenting, and there's a collateral to the LAD because the LAD is actually occluded. Came back 10 days later, he survived it, and you can see that there is thankfully a fairly focal LAD CTO after a diagonal branch with a collateral, but it was actually easily done antegrade, and the stent result was very good. In fact, it was preserved ventricular function on follow-up. I'll show you a very brief case. Not all things are so easy to do. This is a 62-year-old diabetic smoker with angina class 2, hypertension, lipids, and a MIBI scan showing ischemia, and you wonder whether or not you needed any more data. It was only a very small amount of ischemia at the anterior apex. The operator, I didn't do this case, looked at this angiogram. This is the LAD. There's LAD lesions, quite long and diffuse, and then into a LAD muscle bridge. This is in a slightly different projection, and this is in a slightly different projection, showing the tortuosity and diffuseness of the LAD disease in a diabetic patient that smokes. And so they decided, well, they need to confirm ischemia because they weren't so convinced by the nuclear study, and so they did an FFR. It's 0.38, and I think that it was done by the fellow and consultant did not screw up, but just within 30 minutes after finishing the procedure in recovery area, patient had anterior STEMI, severe chest pain, 4 millimeters of anterior ST segment elevation. LAD is occluded now. You can barely see it, but you can see that the wire is down. Difficulty wiring, the wire in the diagonal branch, and 2 drug-eluting stents were placed with IVUS guidance to make sure this is as well implanted since it's the LAD in a diabetic patient. So will a far MI affect my practice? It is a little bit smaller. And did they really enroll very ischemic lesions in that for non-culprit? Hard to know. And of course, if FFR is actually, we can see from this trial, not necessarily mandated by this data set, angiographic guidance is reassuring, it's quite adequate, particularly if your lesions are severe. And no one's going to argue that these will still be severe if the vasospasm is relieved after a STEMI and you recovered. The FFR guidance may be done, perhaps remote from the primary PCI, if ischemia is not confirmed in this territory, and particularly if the diameter stenosis is only around 50% and anatomically low risk. This would lead to a very appropriate revas decision based on the appropriateness of the non-culprit lesion PCI, much like in complete. A precision because precision and more, even if we use an added intracoronary imaging as well, so physiologically proven to be ischemic, to be necessary to do PCI, imaging is done to optimize the PCI as well, perhaps even checking, as you've seen in the trial, what the result would be post-PCI. FFR has cost implications, particularly in Asia-Pacific, and therefore I think there's reassuring data that we may not need it, particularly if the non-culprit is tight and severely stenosed. However, for confirming ischemia, I guess physiology remains the gold standard if there's uncertainty. So I would end there. Thank you very much.
Thank you so much, Dr. Low, for the summarizing a very contemporary and to some extent a controversial topic as well. So the talk is now open for discussion. And I just want to remind the audience that you may choose to send the questions to us online, and we can read the question out as well. So I have actually received the first questions already. Dr. Low, hope you can answer the question that this is about the timing of the fractional flow reserve. And in the context of AMI and STEMI primary angioplasty for non-culprit lesion, the question is, do you think it's a good time to do it during the index procedure, or should we wait? And if we wait, how long to wait?
I think the vast majority of clinicians will probably stage that procedure because a lot depends on how much you have actually done and how much you have to do the culprit. If it took a long time, patient very unstable. If it's a very simple lesion, anytime you do pressure wire into another artery, there is a small risk attached to doing something. That's why I liked that show, the last case. So in general, the overall practice, most of the time in Australia, we would stage that. But remember, you may not need to do FFR. If it's a very tight lesion, you don't need to do it. Now, if the vasospasm is relieved and you're not convinced at the time of the second procedure, then maybe you might go and do an FFR. So you can err on having angiographically guided as a practicality, particularly in Asia Pacific, if cost is an issue. And but if it looks tight the second time, if we come back, now the timing, there's nothing in it. It's not been randomized, so there's no randomized data to drive you. But we generally do somewhere between a few days to a month. If flow reasons is okay, in terms of bed situation in your hospital, then we often do it a few days later if they don't have renal dysfunction and we can afford a little bit of extra dye. We can try to run a low contrast PCI procedure. I mean, if you're doing a CTO, then I would definitely wait maybe a month.
Great. That's also, you partly answered the second question, and there's another question I just received is that for deferred stenting, when would you bring back the patient? Is it a month you just mentioned? Or do you prefer to do it within the same index admission?
Now this somewhat relates to how different countries reimburse their DRGs and episode of care. Sometimes it is driven by what you're allowed to do to be funded for the PCI. And of course, like in the US, etc., episode of care, and also in Australia now, if you are funded in the index procedure, any other procedures, if the qualifying event to be paid in terms of the insurance, you have to do within 30 days of the first procedure, which means that you should do it within the 1 month. This is largely driven by reimbursement. So there are some limitations. Now, there is no alternate. Staging it doesn't hurt the patient. Doing it any time after 1 day is very reasonable. So you can pick your time that you think is the most appropriate. If renal dysfunction is an issue, contrast loading is an issue, then you should wait 1 to 2 weeks, make sure renal function is stable.
All right. Okay.
So any comments from our overseas faculty? Feel free to ask any questions to Sidney.
Can I say something? I think during the early stage of MI, maybe within 3 days, it's not very good to do the FFR because there will be lots of microvascular dysfunction, which may affect your FFR results, which may not be accurate. So you cannot rely on the FFR finding in acute stage. That's my experience. And think about that in the early stage. Actually, we have tried to do FFR in those MI case, but we found that, for example, FFR negative. Then you told the patient you don't need PCI, and then because those cases are at high risk of recurrent MI, and then they come back with MI, and then it will be a disaster for the physician because you just told the patient you don't need, and then a few days later you have to stent the patient.
So Lam Ho, if I hear you right, you are a bit skeptical about doing the FFR too soon, and your worry is it might give you a false negative results. Is that? Am I hearing you right?
Yeah.
Maybe
Yes.
here. This is great because can I throw this question out? And maybe can I get Deepak involved? Deepak, what do you think? What's your practice over the States? When do you do FFR, and do you have some reservation about doing the FFR too soon? Some of us do it during the index procedures, but what's your practice and what's your view of what Lam Ho said?
We typically do not do it at the time of the index procedure for reasons other people talked about. Typically, the PCI, the stage PCI, is done during the index hospitalization, and it's not uniformly FFR guided. Depends on what your angiographic severity is. So that's the general practice. I think I agree with the point that there's physiologic issues with doing FFR at the index event, but also, uh, sometimes at 3 a.m. and you've had a long case, you wire something, there is a chance of something happening, especially if you're working with junior trainees and things like that. If you don't have to get into trouble at that time, it's better to wait, let the patient stabilize, and then bring them back.
Can I share experience?
Yes, please go ahead.
Yeah,
Wei Shun.
I'm Wei Chong Huang from Taiwan. Recently, we published a paper in Frontier Cardiovascular Medicine about the stage PCI and the immediate PCI. So we collect Taiwan National Insurance Database. So we in the immediate multiple vessel PCI group, there's about 14,000 patients, and the stage multiple PCI in the index hospital about 2,000 cases. So in finally, we find that the stage PCI in the index hospital can reduce survival compared with immediate PCI. So I think it's also shows the data in the Taiwan in the situation, but we didn't collect the data for the stage PCI after the index hospitalization. So I think in our daily practice, usually we will not do the FFR in the same time with primary PCI. So in some of cases, we will maybe do the 2 copy-based or multiple PCI. But I think the stage PCI may be more safe, as Sidney mentioned about reduce injury of renal function or volume expansion.
Okay. Thank you for that. I just want to comment about the physiology. I think that Lam Ho has mentioned about when you're infarcting the microcirculation in a big way, you may actually make your FFR more normal. And this unknown because it's not been well studied, at least in the index procedure. Currently, there's a study called Restore MI looking at the function of the microcirculation with time and during acute myocardial infarction. And there's a suggestion from my colleagues who've done that, is that it's highly fluctuant. And so the question really is the IMR going to be, when does it recover? When does it become so fluctuant? And we don't really know. In non-culprit vessels, as you know, the famous study, other studies have suggested it's okay sometime after your STEMI, but of course not. The next procedure is a little bit doubtful. But I guess if you have a negative study, it's not so reliable. If you have a positive study, maybe it's okay. And so there is a real issue with that. And of course, if it's really a large territory, I don't think you need to do an FFR in the index procedure. Why would you need to do it? You can just fix it. If you think that this needs to be revascularized. If there's any doubt afterwards, I think that's reasonable to justify that because you're not the index case. So I think let's not overcomplicate the primary PCI procedure.
Thank you, Sidney. We actually have received quite a number of questions on different versions of FFR. So the audience are quite keen to know your view on IFR and also the QFR using angio-based FFR. Do you have experience on that? And what's your thought on that?
Yes. So okay, number one, resting ratios or non-hyperemic pressure ratios. Obviously, they've not really been studied. Once again, we're talking non-culprit lesion issues. And essentially, of course, the studies will suggest that and FFR, they can coordinate 80% of the time. And so it's very reasonable at some time in your non-covered lesion stage PCI, if it's necessary to use it, you may use that as an index for determining ischemic potential of the lesion. If that's the question. Now, it is unknown, is not well studied post-PCI, and data is gathering because the index is resting. And so when you fix that lesion and using a non-hyperemic pressure ratio to describe hyperemic flow after a stent, that's a little bit unknown. And but in any case, in defined PCI and moving forward, defined GPS, we might have more indication about the data set. So yeah, you can use IFR, a pressure Y index, reasonable. So in terms of, sorry, the second question is about QFR. And of course, we have not had a great experience with QFR. And in the beginning of the initiation of QFR, we're just a bit concerned regarding it's a user-dependent process. And so it's easy to get wrong on the QCA. So there's a slight error rate attached. And so not so reliable, and it relates to flow. And as you know, flow is assumed in that you can do it either with an assumed flow or a frame count. And so unfortunately, I think that in infarcts, the QFR may actually make it more difficult. As you know, the frame count, even in non-culprit vessels, or the flow in non-culprit vessels is reduced during a STEMI. And so unfortunately, it will probably muck around with the QFR unless Paul and KY have more experience with QFR. They may have an experience that I don't know, maybe they can comment. But I think in my theoretical assumption is that we have not been using QFR in STEMI, and I think that there is an increased error rate.
Thank you so much, Sidney. In the interest of time, I think I will wrap up the section and move on to the next presentation.
Okay. It's my pleasure to introduce the next speaker for the talk on cardiogenic shock, whether there's a paradigm shift. So the talk is pre-recorded by Dr. Lee Kwan Seung. We fondly know him as Kwan, and he's currently the associate professor and the director of the Cath Lab in Salver Heart Center in Arizona. So he has prepared a very nice case for us. The reason why he can't join us this morning is because he has gone hiking in the Grand Canyons, so there's no internet access. And his great colleague, Dr. Deepak Acharya, has kindly joined us to answer some of the questions. And Deepak is also an interventional cardiologist and has extensive experience in mechanical circulatory device such as Impella, and as well as a heart transplant program. So we can show the talk by Dr. Kwan.
Good afternoon. My name is Kwan S. Lee, and I'm an interventional cardiologist pre-recording a case here for you from the University of Arizona in Tucson, Arizona. I would like to start first by thanking Dr. Ho Hee Hwa and Dr. Paul Ong for their kind invitation to be part of the Asia Primary Angioplasty Congress, and for this opportunity to present this case of cardiogenic shock in STEMI, a new paradigm shift. There have been many advances in the field of cardiogenic shock, especially in STEMI, over the last few years. But I think there are still many things that we need to work out, despite the availability of an increasingly wide menu of devices to assist with the management of shock. And I hope that this case will highlight some of the challenges in both the definition and the choice of therapy. These are my disclosures. This is a 53-year-old African-American gentleman who presented to my emergency room 4 years ago. So this is a pre-COVID case when the world was normal. And he presented with an acute posterior STEMI. He complained of increasing shortness of breath to shortness of breath at rest and chest pain, which progressively had worsened over the prior 3 days. His background history was significant for diabetes, hypertension. He was a smoker. He had COPD and a history of cocaine use. At triage, his heart rate was 98 beats per minute. His blood pressure was 155/80, so he was not hypotensive. His O2 sats, however, were 83%, and his respiratory rate was 32 breaths per minute. He was tachycardic with a gallop, and there were no audible murmurs, but there were diffuse crackles bilaterally. This is his EKG on initial presentation prior to subsequent decompensation. And you can see here that he has a posterior STEMI with a bit of an R wave and ST depressions in the anterior septal leads. An attempt was made to perform a chest X-ray, but he unfortunately acutely decompensated with rapid desaturation to 65% and became apneic. This required emergent intubation. And even though we pushed his FiO2 up to 100% with a PEEP of 15, we found that the O2 sats remained borderline at 80%. And we required aggressive manual bagging to increase the sats to maintain them at 90%. At this point, he was still normal to slightly hypertensive and had no vasopressor or inotrope requirement. A chest X-ray that was performed to confirm the position of the ET tube showed diffuse severe bilateral pulmonary infiltrates, presumed to be pulmonary edema, and not much cardiomegaly on chest X-ray. His labs came back in, and his CBC was normal, except for slightly elevated white cell count. His BMP was normal with normal creatinine. His troponin, and this is not high sensitivity, troponin I was 10.8, so moderately elevated. His BNP was not very elevated at 244, and his cocaine test came back positive. The emergency room physicians performed a post-intubation ER bedside echo, and they noted to us that he had mild LVH, that the LV size looked normal. The left ventricular ejection fraction was 70%, and that they couldn't see any valve problems on color Doppler. There was no pericardial effusion, and the right side of the heart looked normal. So, what was the diagnosis? Suspecting a severe mitral regurgitation and recognizing that in acute severe mitral regurgitation, the changes occur so quickly that you may not hear a murmur and that you may not see color Doppler changes. We elected to perform a left ventriculogram immediately upon access to confirm the diagnosis. And here we had a femoral access and a angle pigtail in the ventricle showing a normal left ventricular size, a hyperdynamic anterior wall and apex with akinetic inferior wall from base to mid, as well as a clear severe mitral regurgitation with complete opacification of a large left atrium. At this juncture, the patient from the 2019 SKY proposed document for the classification of cardiogenic shock fell under the category of B, i.e. stage B, beginning cardiogenic shock, a patient who has clinical evidence of relative hypotension or tachycardia without hypoperfusion. So he's not hypotensive yet. However, it's important to note that there are no modifiers for the mechanical complications of cardiogenic shock. We have modifiers for cardiac arrest, but not for mechanical complications of cardiogenic shock. So you could argue that this schema, although helpful, does not necessarily apply to him because he's actually a lot sicker than what is being labeled out here as class B. What is the best course of care at this point? Emergent surgery consult, vasodilators with nitroprusside and nicardipine, placement of an intra-aortic balloon pump, ECMO, impeller, or just revascularize and buy some time. I think the choice of therapy has to be taken in the context of remembering that the patient is hypoxic to 80% on maximal support and is still normotensive. With the struggle to maintain oxygenation, even as you make decisions as to the exact moment, you have to take into account the fact that if you cannot maintain oxygenation, whatever you do when it comes to the mechanics, the patient likely will not survive. When we look towards our guidelines for guidance, the 2020 ACC/AHA valve guidelines has a section on acute severe MR, but has no guidelines. Within the section, it states that vasodilator therapy to reduce afterload is helpful, but can be limited by hypotension. And IABP can be helpful, and cryptically, they say the use of a percutaneous circulatory assist device may stabilize the patient. The 27 ESC valve guidelines, there is no section separating acute MR, and they just make a very brief statement about vasodilators, diuretics, inotropes, and IBP. The 2017 ESC guidelines for STEMI recognize that acute mitral regurgitation may complicate, but there are no statements on the optimal therapy. The 2013 ACC guidelines for STEMI have a separate section for mitral regurgitation, but once again, there are no guidelines. They recognize that the primary mechanism are either that of papillary rupture or functional MR from tethering or hypofunction of your papillary muscles. With papillary rupture, they say consider for urgent surgery because clearly there is no therapy that would improve a papillary rupture while you stabilize with medical therapy and an IABP. For functional MR, they say that you can try to reperfuse the patient first and try and get a regain function back in the papillary muscle territory, use diuretics and afterload reduction. So what did we do? We chose, or I chose at that point, right or wrong, to ignore all of the guidelines. I upsized my femoral access sheath for a 14 French sheath, and I placed an Impella CP achieving 3.1 liters per minute of flow, and this CP is capable of achieving a maximum of 3.5 liters per minute of flow, and then obtain 6 French right radial access to visualize the coronaries. The reason for the choice at this point was that I felt that it was extremely important that we rapidly decrease the size of the ventricle, and in the hope of reducing the amount of mitral regurgitation, because we were really struggling with oxygenation. And I felt that an intra-aortic balloon pump or vasodilators would take possibly too long and not allow us to pull out of the spiral. So definitely a controversial approach. So here is the Impella CP, which was placed via the right common femoral approach. The angiographic shots, see the left main is fine, the LED in the AP caudal view is fine, and that there is an acute occlusion of the mid-left circumflex with minimal left-to-left collaterals to some OM, as well as signs of left-to-right collaterals. And the question obviously was, is the right acute? Here is a cranial view showing that the LED is all right. We can see more left to right collaterals via the LED and its septal perforators, and minimal left to left collaterals. And the right coronary artery is diseased and does not appear to be acutely occluded. And so this we felt was a CTO. After the Impella was placed, this was a clinical response. The O2 sats, as we expected, began to climb from 75% to 80% over 15 minutes on manual bagging. At that point, our ABG showed a PO2 of 89, a PCO2 of 36. He was still acidotic with a pH of 7.2, with a bicarb of 13.8 with metabolic acidosis, as well as a lactate level of 6. So he's certainly hypoperfusing at this point, possibly just directly related to the hypoxia. The surgeons who saw him, and in the United States, it's worthwhile noting that many surgeons, unlike in Asia, tend to be a bit more conservative because of their public reporting of the outcomes. So they decide that he's too sick for surgery, which places the ball back in our court. During the discussion with surgery and this bagging, he develops AIVR initially, and then the pressure waveform essentially becomes non-pulsatile at 30 millimeters mercury, somewhat akin to pulseless electrical activity, but that is really non-pulsatile waveform of the Impella support. So in many ways, I think at this point, we are somewhat vindicated by the use of the Impella, because without the Impella, I think at this point, he probably would have simply crashed out and not survived. We administered intracoronary epinephrine with immediate and dramatic response. And you can see that his blood pressure now shoots up to 203 over 117 millimeters mercury. He once again has a transient systemic perfusion. An IV adrenaline infusion was started. A Cath Lab TTE briefly confirmed, because at this point we were wondering, hey, is this a papillary muscle rupture, or is this just ischemic MR, functional MR? This showed the persistent mitral regurgitation even with the impeller in. Ejection fraction now is getting lower at 40%, probably just because it's becoming more acidotic. There was non-opening of the aortic valve, as you would expect from a non-pulsatile systemic waveform, and the impeller with non-pulsatile flow. The MR did not seem to be due to papillary muscle rupture at this point. The non-pulsatile pressure would intermittently fall to 40 millimeters mercury, but this would respond to increasing the peripheral IV infusion of dose of adrenaline. We were, with this support configuration, able to wean off manual bagging and maintain 91% SATs on maximum PEEP and 100% FiO2. And correspondingly, we saw that the ABGs improved. The PO2 went up to 88, the PCO2 went up to 47, the pH was 7.3, and the bicarb was 23. And this is a picture of that new stable state with the non-pulsatile flow and the persistent, every beat was generating persistent mitral regurgitation, although not as severe. And he was entirely being supported by the impeller CP device. Here, we then decided to proceed and revascularize to try and see whether we could get back as much function as possible and decrease the ischemic MR. Because of the possibility of proceeding with surgery, we felt that we should attempt to simply PTCA without placing a stent. So this is the balloon going up in the mid circumflex, and this is what we saw behind it. Clearly, there's a bifurcational origin of OM right at the spot. There's some ostial OM disease. We unfortunately don't have drug-coated balloons in the United States, and which would have been a very nice option. So we simply elected to bifurcation wire and perform kissing balloon inflation. And then this was the final result, with the hope now that he would stabilize, improve, and maybe not require surgery. So at the end of the case, he remained on high-dose IV adrenaline with non-pulsatile flow. And unfortunately, despite all of what we did, his mean blood pressure at this point was 40 millimeters mercury with the impeller CP support at 3.3 liters per minute. The SATs were more stable at 94% on maximum PEEP at 15 and 100% FiO2. So, at this junction, it's worth relooking our patient and recognizing that your patient can change sky shock categories quite quickly. And he had gone from B to essentially D, deteriorating or doom. A patient that's similar to category C, but getting worse, they have failure to respond to initial interventions. And once again, it's important to note there is no modifier for mechanical complications of cardiogenic shock, which means that our patient is D++. So what should we do next? We see that our systemic pressure is 40. We're running out of inotrope options. What are our goals of therapy? Is this a bridge to recovery or a bridge to surgery? So these were the options that we considered at this point. Should we increase the vasopressor? Can we consider the addition of VA ECMO? The one thing to note that when you add VA ECMO on board, you will increase the afterload, and it's possible that you will make the mitral regurgitation even worse. And you may get complete whiteout of the lungs, which will be persistent. Although it's possible that the decrease of preload may actually also decrease the degree of mitral regurgitation. It is hard to predict. Can you consider VV ECMO just to improve the oxygenation? But once again, this will do nothing for the mitral regurgitation, and maybe use them both in combination. You can consider a bit more of a sophisticated circuit where you do a VAV ECMO, which would basically avoid the Harlequin syndrome and be able to oxygenate while also providing enough forward cardiac output. Can you upsize your impeller to a 5 liter per minute device? And that needs to be a surgical implantation. Or alternatively, could we just add an intra-aortic balloon pump? And this sounds crazy, but I will explain why and what we did. So here is a picture before we do that of an echocardiogram showing you that this was what was going on at the end of the case. We see that there is persistent mitral regurgitation. The ejection fraction actually looks reasonable despite the fact that we have no pulsatile flow, because all of the ejection is actually going forward while the impeller is decompressing and providing the forward output. What you can't see clearly here is that the aortic valve is still not opening. Here is a closer view of the ischemic mitral regurgitation and the lack of obvious papillary muscle rupture. So I actually decided to add an intra-aortic balloon pump. And the rationale for this was stacking an intra-aortic balloon pump timed to the ECG. Clearly, you cannot time it to the pressure waveform because there is no forward pressure waveform. Can actually increase your systemic perfusion pressure. Note that in the beginning, our systemic perfusion pressure was 40 millimeters mercury. And also in anticipation that with reperfusion, we were probably going to see some downstream progressive improvement. And I did not want to escalate before trying this. So we put the balloon pump in with the goal of generating a greater systolic mean pressure. And the pulsatility of that pressure went up to 81/34, as you see here, with a mean of 50 from the mean of 40. Okay, and this was a transient experiment in many ways, and very unusual, I think, and that's why I think it's an interesting case worth discussing. It did work, and obviously we were reserving in the back the possibility of moving on to ECMO. He stabilized over 2 days. He did develop hemolysis with the impeller and ventilator-associated pneumonia, which placed him further and further away from being a surgical candidate acutely. The TEE was performed, intubated, and this confirmed ischemic mitral regurgitation with no mechanical complications. The impeller, because of the hemolysis, was removed on day 2. We left him on intra-aortic balloon pump as his wall recovered, and the IABP was removed on day 3, and he was extubated on day 4. His long-term course, the surgery was very reluctant to take him. We did bring him back and just do PCI of the circumflex with a provisional bifurcational strategy with a resolute DES at 1 week. We tried a RCA-C2O attempt. He could not tolerate it. And the mitral regurgitation, unfortunately, remained severe. He had a difficult hospital course. And ultimately, as he recovered from his pneumonia, etc., he did undergo mitral valve surgery with a bioprosthetic mitral valve replacement and 1 vessel SVG to the PDA a month later. And he did well to 2-year follow-up, after which I think from his lifestyle choices, he disappeared from our system in follow-up. So discussion points, and I'm sorry I'm not able to physically join you today, but my colleague, Dr. Deepak Acharya, will be joining the distinguished faculty of the APAC Congress to hopefully represent me. I think we should focus around recognizing mitral regurgitation complicating acute STEMI and its effects. Be aware of the pros and cons of the various support devices to assist in unstable STEMI patients, i.e. the IABP. I think that's the most relevant one for the Asian audience. Impeller, which I suppose is growing and coming up, and also how to use ECMO in all the configurations, VA, VAV, VV, when you're trying to support your decompensating STEMI patients, and also exactly how to use these devices. So thank you once again, and I hope you will have an exciting and productive discussion.
I think that was a fantastic case shared by Kwan. I honestly do not know how the patient could have survived. He was so very extremely acidotic and was very, very sick. So just want to ask Deepak, I know you're standing in for Kwan. Would you have done anything differently? And could you have thought of mitral clip to solve its problem at the acute stage?
Sure. So, one of the reasons we chose to show this case was because it was so unusual and it would generate discussion as to how everybody would have done things. You could make a case at that early stage just to put in a balloon pump and revascularize and see what happens. So that would have been certainly one approach. And you had the option to escalate as needed in terms of mechanical support. The major issue in this patient was the inability to oxygenate. So if that had persisted, you could go to ECMO. Then the issue again becomes it's a more complicated mechanical device, and there's issues of afterload, and you would need some sort of unloading. Obviously, if you had surgeons willing to take him right away, that would have solved some of the issue as well. So a lot of this would depend on your individual center experience also. I think, again, there's different ways of doing this. I think if I had this case, I would have probably just started with a balloon pump and then see what happened. And then you have the option to see where we are. But I think Dr. Lee's concern was, he was difficult to oxygenate and he wanted to be able to offload the left ventricle as quickly as he could prior to revascularization. So that's where the Impella came up. Certainly nowadays, with the increasing experience with mitral clip, that is a viable option. This case was about 4 years ago. At that point, there wasn't a huge amount of experience with mitral clip in acute cardiogenic shock. So that we did not feel, at least in our institution at that time, was not a viable option for somebody this sick. This was a interesting case. Things happened in a very roundabout way, and he still ended up doing okay. But I think, there were multiple ways to escalate. And I think part of the discussion would be that, cardiogenic shock, we talk about it like it's one thing. It's really not one thing. A cardiogenic shock you have from an acute MI, especially an early presentation where the stunning can resolve, is a very different beast than the chronic heart failure patient who develops cardiogenic shock. The person who has late presentation versus early presentation, post cardiac arrest or multi-system organ failure, even if the hemodynamic abnormalities are the same as somebody who presents early, is a very different person because they may not recover even with everything. So I think one of the things is, cardiogenic shock is not one thing. It is a very heterogeneous condition. Things like the SkyShock algorithms try to get a easily calculatable or, get a gestalt for how sick the patient is. But that still leaves a lot that is, not accessible just by using those scores. So I think individualized decision-making in this is very important. And there's not a standard necessarily one way to do it. Oftentimes you do your first thing and then see what happens, and then you see then you decide on the next thing.
Yeah, thanks very much, Deepak, for your input. Any questions from our faculty? Yannick?
Hi. Thank you very much for that discussion. I think the topic on cardiogenic shock is very relevant and practical these days, particularly because we are getting a lot of cases of late presentation, and then we get them already with mechanical complications of MI, like ventricular septal rupture or torn or rupture of the papillary muscles. I think the case also kind of vindicated IABP use, because there was one time when people were shying away from using IABP because of the IABP shock trial results, and now we are realizing that IABP may still have a role, particularly in patients with PSR and acute MR. Okay. In this part of the world, not everybody has Impella. In my center, we have both IABP and ECMO. So I guess this is one of the situations where we can use both.
Hello.
Yeah, David, yeah.
Yeah, thank you.
Wei Chun, yeah, go
I
ahead.
think this is yes, thank you. This is amazing cases. I think the cardiac shock is a very good issue for the cardiologist to save. And in this case, you use Impella. I think Impella is a good device because it provides axial or flow continuous pump compared with IBP or ECMO. But unfortunately, in Taiwan, we don't have Impella. Usually, we have to use ECMO or IBP. But I know IBP is most useful in presence of ischemia, but it will not produce the oxygenation. But Impella or ECMO can use in non-ischemia or increase the blood pressure and also produce more oxygenation compared with IBP. In previous, we published a paper about acute coronary syndrome with severe MR patient. So we collect 1,000 cases with ACS with MR with different severity. We collect about 95 patients with severe MR with ACS. About 60% we only do the primary PCI only, but 40% we did the CABG and the MR, mitral valve replacement. So in final, we find that the CABG with mitral valve replacement can improve the long-term event, including the heart failure and the all-cause mortality. And also acute phase can improve the prognosis after adjust with the age or the feeling pressure. So in our center, usually with CABG, with ACS or acute MR, we will transfer to the CABG and the MBR first because maybe can improve the patient's long-term or short-term outcome. So I have a question about these cases. So if after you choose IBP, what time would you transfer the patient to the CABG or and the mitral valve replacement? Thank you.
So I think if once you're reasonably satisfied that the stunning has resolved and you still have ischemic MR, then you would start thinking about either CABG or a clip in these days. I mean, in this particular patient, he had other infectious complications like the ventilator-associated pneumonia that delayed his surgery. He also the initial vessel, the culprit vessel, was angioplasty and had flow initially, even though there was no stent. So that part at least was out of the equation, at least as a urgent emergent thing. So in this kind of a situation, if they are stabilized and he was able to be weaned off of the Impella and a balloon pump within the next couple of days, I think within the next weeks, because you don't know, how the ventricle is going to do in terms of the geometry and the size. I think if they can be stabilized, it's not unfair to wait a few weeks. Because clearly, if he was able to come off of everything and was just on medical therapy, you didn't have a pressing reason to push ahead right then if he had other issues such as pneumonia.
Okay.
Sidney, you have a comment?
I think Lam Ho as well, but I wanted to understand, and I think I've learned also that number one is recognition of the shock state of the patient. And I think what we've been doing locally is doing at least a blood gas before and after the primary PCI. We're very keen to stick stents in and open up the artery. Sometimes doesn't help a lot. And of course, as you mentioned, there are different types of shocks. Right ventricular shock, and we published on this, proximal right coronary artery can infarct your right ventricle. And so sometimes it's RV shock, bradycardic shock. And we didn't do an echo. Sometimes it's so quick into the lab. So a VSD, they didn't know they had ventricular rupture, things that will just burn you very quickly. So an echo, blood gases, and even now, I think we're moving back to doing some right heart caths, even after the PCI, the stent goes in. And I think that then you can understand and maybe speak to your colleagues, do a shock team meeting, so you understand, because otherwise they leave the lab and they're going to do badly because you've been so quick at putting a stent in. So for primary PCI operators, just be mindful. A blood gas may be very helpful to tell you what's going on. And hemodynamics in this case originally didn't look too bad, but it rapidly escalated, rapidly deteriorated. So I think that you get burnt, you didn't listen, you didn't echo. Those things may help you a lot.
So,
Lam Ho have something to say?
Yeah. I think it's a very great case because it is 4 years ago. It gives we don't have much experience on impeller on acute MR. This case gives us the picture, the experience, the clinical course. I noticed in the presentation there are two important features that happen. One is hemolysis, and the other is flattened, low pulsed tau waveform with the impeller putting in. Am I right? So I try to postulate the thing about the mechanism, what is going on behind for impeller in acute MR. With the impeller in the acute MR, when the heart contracts, the blood will go to atrium. That means the LV size will decrease. There's not much blood inside the LV when it press the blood go to. That's why when the space reduce, then it will increase hemolysis with impeller. And because of the patient in cardiogenic shock, you will keep the impeller in a very high rate, for example, P8, P9, something. Then with such strong suction force, decreased volume, that is the cause of the hemolysis. And the other cause for low pulse tau waveform is because the blood go to atrium, and then when the heart contract, the blood cannot open the aortic valve. That's why all along is flattened. But it shows the effect of impeller. At least it can draw some blood from LV to the aorta, and then it can supply. So I'm thinking, will it be better if we use ECMO plus impeller? Because the ECMO actually settle the oxygenation problem. And then for impeller, the impeller, you just need to keep P1 or P2, very low suction, and then you just try to unload the LV only. Keep the LV without following a cord, and then that can reduce the hemolysis. And the waveform is not important anymore with impeller. I'm just thinking about this situation.
Yeah, I think that certainly would be a good approach as well. The hemolysis, sometimes it can be related to the speed, certainly. Sometimes it can be related to the outflow cannula position, especially if it's very close to the aortic valve and you're getting turbulence there. Sometimes it can be also related to what your anticoagulation process is. So it is sometimes hard to know for sure what the hemolysis is from, but certainly ECPella would be an appropriate option. And the plan was, if this didn't work, was to go to ECPella at that point.
I think, thanks, David. It's okay. I think it's time for us to have a coffee break.
Yeah.
Before we move on to our coffee session with the experts. I think some of the questions we can have the discussion during when we have the coffee session with the experts. So I think feel free to drink your coffee right now. So can we have the slides for the coffee session with the experts? So Paul is going to start the first question.
Okay, okay, we can hear all the coffees slurping. Okay, so when would you perform thrombus aspiration in primary PCI, especially a very large thrombus? Okay, so we will prepare some questions, but please, if the audience have any questions, please come on board. So this question, Ashley, you've been very quiet, and Dr. Tavik, you've been also not involved much. So can I get Ashley first, and then Dr. Tavik can help out?
Hi, sorry, it was very interesting discussions and cases. I have not left aspiration completely, and especially ectatic vessels, large RCAs, and so on. I think if you suspect, when you look at it, a lot of thrombus burden, acute occlusion. But nowadays, actually, whenever I do aspiration, I also use GP2B3A inhibitors upfront. So actually, I'm quite a fair bit user of GP2B3A inhibitors, IV, that is. And I've actually progressed. I still use a manual aspiration, but if I have problems, then I'll go to the penumbra system, which I find that it's better than my previous usage of AngioJet and so on. So I still do use aspiration, especially in large thrombus burden lesions, especially RCA and ectatic. So that's what I do. Yeah.
Thank you. What's happening in Indonesia?
Okay, thank you. If I meet the huge thrombus in primary PCI, we do angioplasty first, and then we proceed to mechanical aspiration. And with NC, if we see in the flow, can get a TME3 flow, maybe we evaluate the atherosclerosis. We have to put the stent or not. If we cannot put the stent, maybe we staging for PCI for the next stage. That is my dream.
I hear you right. You will follow the guideline. You will do the ballooning first. You do the POBA first. And only if the POBA did not restore TME3 flow, then you do the mechanical aspiration. Am I hearing you right? Okay.
Yes.
Okay, great. Now, early on, there was some mention about if, using the penumbra aspiration catheter and AngioJet. What's your experience with that? Do you have that in Indonesia yet?
I didn't do with the AngioJet, only in the mechanical aspiration with microcatheter. Before it, we give the GP2B3A, and then what the result, the flow. If we can get the TME3 flow, maybe we can put the stent. And if we cannot get the TME3 flow, maybe we stage for PCI for next stage.
I hear you loud and clear. So maybe I will throw this question to Lam Ho. You have all the gears and toys over in Hong Kong. So if you can't get flow back, what's your plan?
For fungal aspiration, we still do some in selected case, but not routine as before now. I think I will not always think about mechanical or manual fungal aspiration. I will also think about pharmacological therapy, for example, 2B3A first, or isolytic, and then think about the fungus aspiration. I think AngioJet is out now. For the manual or mechanical fungal aspiration, I can say remember is better than manual in almost all situations, except one situation is a fast aspiration you need. In this way, manual aspiration is still better because you can set up the equipment quickly and then take it out. In what situation this will happen is, for example, oxyl AAD cord. When you do something, the oxyl AAD cord go to the circumflex, the patient immediately will short arrest. Then you have to quickly settle the circumflex cord. Then in this situation, manual aspiration will be better because you can done it in a quicker way.
Okay, great.
Otherwise,
thanks, guys.
mechanical aspiration will work much better.
Okay, great. So if I hear you right, is restore flow. So balloon first, aspiration, manual aspiration, mechanical aspiration, 2B3A, and also think about defer and stents at a later date. Okay, so on that, I'll move on to the sorry, Hui Chen, I probably have to hold. Can I move on to the next questions?
Yeah, can we flash the second question?
Yeah. Can we go back to the PowerPoint, please?
Okay, we can see the question.
Okay.
So the second question is about choice of therapy during primary PCI. So whether you're going to use a durable polymer stent, biodegradable polymer, polymer-free, or we use the ultra thin DES. Maybe Rachel, you can take this question. I understand that you use a different stent in Taiwan for primary PCI.
Yes, in Taiwan, actually, our insurance only reimbursement for the BMS, so the patient have to pay for the DS. Actually, the patient have also pay for the DEB as well by themselves. So in Taiwan, usually the first stand, if patient didn't put the agreement, we will put the BMS first. But if the family agree, we will put the DES. I think the DES from the recent study, DES in the primary PCI is definitely better than BMS. But the DCB, maybe in some of cases with instant occlusion patient or instant retention patient in primary PCI, we will use DEB because national insurance reimbursement for this condition. As mentioned, if distal part of the small lesion, some cases we will use DEB, but not very frequent. Thank you.
Okay. Yeah. How about you, Sidney? What choice of stents do you use in primary PCI?
So we in the public hospital we have a tender. So we use a standard tender DS. Now they're usually, as you say, about 80 micrometers. We did a little local study with the thin-strutted stents, such as you mentioned, or Syro, etc. And I think that they all perform very well. So for the audience, I don't know that there's a huge difference, even though I've seen the bio-STEMI data. And I think that the one thing I would say that if I image all my cases, so essentially, if you know the stents are well deployed, I don't think that that's necessarily bad. So I don't care how big the stent struts are. Number two is that also, of course, ultra-low thin-strutted struts are easier to deploy at low pressure. So probably it's more stent expansion of deployed stents. And they may not do so well in a calcified, complicated lesion. That's all I would say. If you know they're well deployed, it should be good.
Okay, thanks. So we can move on. Okay, Azri, yeah, you have the...
Yeah, I agree, Dr. Sidney. And the other consideration is whether they're HBR patients, high bleeding risk. So if there are high bleeding risk upfront, I will rather use something with short DAPT like the Onyx and so on. So that will actually guide my stent placement. Otherwise, not much issues if I image the patients. Thank you.
Okay, good point. So we move on to question 3.
Okay, the question 3 is a very interesting question that I like so much. It's about intracoronary imaging in the context of primary angioplasty. We know that intracoronary imaging has been available for use for over a long time. And more evidence shows that improves stent expansion and also improve patient outcomes as well. But in the context of primary angioplasty for STEMI, I want to know your guys' experience on when you would choose using this imaging technique, and would you prefer IVUS or OCT? I want to hear experience, Dr. Cruz from the Philippines. What's your preference and your practice?
For acute cases like STEMI, definitely if I'm in doubt whether I'm dealing with SCAD or spontaneous coronary artery dissection, I would definitely image first before I decide to stent. So for SCAD, definitely. OCT versus IVUS. IVUS may not give me good pictures, but if there's a strong suspicion that I'm dealing with SCAD, then IVUS may be enough. If in doubt, maybe I'll be very, very cautious in using OCT. Well, another situation where I would definitely use imaging will be in cases of stent failure, like in-stent thrombosis, because I want to know the mechanism of stent failure. And probably in this situation, I would prefer to use OCT versus IVUS. But again, IVUS is still good. There are other, I'm sure you want to know the mechanism of of STEMI, for instance, is this pure plaque rupture or just erosion, or is this calcified nodule? These situations also, again, would definitely validate the use of imaging. I'm sure the others have more things to contribute.
What's the percentage of cases that you use imaging, Dr. Cruz?
For STEMI, is probably about 50% for STEMI.
Okay. Thank you so much. Can I ask Dr. Lampo from Hong Kong, in your practice in primary angioplasty, how often you use this imaging and what's your preference?
For us, we probably use around 90 or more than 95% primary PCI we use imaging. Most of time we use IFAS. For OCT, we also use in selected case. In STEMI, there are some situation that, for example, in angiogram, you see some suspected haziness, but we are not certain what is going on. Then we will use OCT, and then many of time we can identify that there actually are big clots inside. And another situation is those definitely MI, but angiogram completely normal. For example, it's AAD, and then you do a OCT one, you see sometimes you see some rupture part or something. That may help, but most of the time is IFAS, because we usually do not do P-imaging. We just wire balloon, keep the flow, maybe quickly stand, and then post-imaging to determine the apposition or the expansion of the stent, and that is our usual practice. Maybe Sidney can share more about their practice. For oscillation, aortic oscillation, we will not do OCT.
Thank you, Dr. Lam. Very impressive. 95%, I think we all have learned from your practice. Is great. So I think, should we move on to the next question?
Yeah. Of course, Lampo is the founding chair of the TCIP, the Transcontinental Imaging and Physiological Course. So he is higher than others. Okay, can I show the next questions? I think it's a question about multivessel disease. Yeah, multiple vessel disease, STEMI, timing of stage PCI. I think, Sidney, I won't ask you because you already talked about that. We're going to hear the others talk about it. Now, but I've been reminded, I think, from personal experience, sometimes you want to stage a PCI, but patient may not come back to you. They disappeared. They wander off, and they no longer want to come back for another procedure. So you actually might miss the chance if you stage it too long. But I'd like to hear the opinion from in America, and I'd like to hear the opinion from Indonesia. So can I start with Deepak? What's your take on that?
Sure. So I think most people would do it during the implant hospitalization at a separate sitting from the index PCI, and typically angio-guided most of the time. One of the issues we also run into is, depending on your practice pattern, many people are not insured, and if you discharge them, they may not come back, or even if they want to come back, now they're coming for an elective outpatient procedure, and there's a large copay that they have to pay before they're led into the hospital. Whereas if you do it during the implant hospitalization, those kind of things are not an issue. So there's some logistical things as well. But from a clinical standpoint, typically angio-guided implant hospitalization, second sitting.
Okay, that's really a good point. If you don't get them done same time, they may not have money. Money become an issue. What's happening over in Indonesia, Dr. Taufik?
Okay. We do the multivessel disease in STEMI when the patient is in stable conditions during primary PCI. But if the patient is stable, we see until hospitalization. If there is no problem until hospitalization, the patient can discharge, and then we do the stage PCI in the next meeting. Because yes.
What about imaging? Do you get involved using in multivessel disease? Do you get involved? We kind of mentioned that earlier, but what's your use of imaging and physiology in these settings, in the stage PCI setting?
In the stage PCI setting, we do the functional physiology like FFR, and then we only use the OCT. But
Okay.
actually, in the primary PCA, we didn't use or rare using the coronary imaging during primary PCI.
Okay, I see. Okay. One thing that I sometimes share with my fellow is I sometimes do the primary PCI, it's fast and furious, get it done. But I do the index like a lot of you would do during the index admission. I would do the stage PCI. And when I do the stage PCI, the coronary imaging comes back in to further optimize the stents that was put in during the culprit situation, because a lot of time the coronary artery spasm sizing may be undersized, so that's quite useful. But Astrid, you put your hands up.
Yeah, I think like what Dr. Sidney mentioned, Dr. Deepak, I think the reimbursement actually, guides how we actually do our stage procedures and so on. In my hospital, reimbursement is not really a problem, but cost is also an issue. So when it comes to imaging and physiology in acute MI setting, we rarely use FFR. Nowadays, I also use a bit of IFR, but I think it's also determined by how well you do your initial PCI. So if you have issues, prolonged procedure, and if you have a slow flow in the culprit artery, I think you'll be very careful. Number two, if you've got a CTO lesion, I'm always doubtful of the FFR finding. So I tend not to do it. But most of the time, we'll stage it within 2 to 3 weeks, maybe not within the index procedure. Thank you.
Okay, we move on to the next question. So the next question is got to do with cardiogenic shock, and I think in Asia, I think we still use a lot of IABP, and I think in Taiwan they have a lot of extensive experience with ECMO, and in America, I think there seems to be a shift towards Impella. So I'd like to direct the question to Dr. Deepak, because the recent SKY meeting shows that the National Cardiogenic Shock Initiative shows there's a high survival rate at 30 days up to 70%. And we understand that this is a single arm registry. And it seems like in USA is the default mechanical device that you implant. So what are your thoughts on that?
Sure. So, after the IABP Shock 2 trial, the intra-aortic balloon pump use has gone down some. Now, the National Cardiogenic Shock Initiative started as something called the Detroit Cardiogenic Shock Initiative. And it's not just the Impella. So Impella is one component of it, but it was also earlier recognition, having pre-existing relationships between hub and spoke hospitals, doing hemodynamic assessment, checking your LVEDP cardiac index early on, doing, if you're going to do a Impella, doing the Impella prior to the PCI for thought that there may be some reperfusion injury, that if you are unloaded at the time of reperfusion, that may help with that part of it. Checking your cardiac power output and your pulmonary artery pulsatility index to look at both to check adequacy of flow, cardiac output, as well as your right-sided support or right-sided function, and then also escalation. So it's not, so what I think is more important is having an organized system of shock care that gives the right therapy to the right patient. So even though the Impella use has gone up substantially, but still the vast majority of patients who present with cardiogenic shock are still not getting Impella or balloon pump or many devices even now. If you look at randomized controlled trial data, the data there's not really very good randomized trial data. So the IABP Shock 2 trial, obviously no benefit in unselected use. But again, that was a very heterogeneous population. So there may certainly be some AMI subsets that may benefit with a balloon pump versus Impella versus something else. But I don't think as of now we have defined those subpopulations. Same thing with the Impella. The only real randomized controlled trial was the Impress shock trial. And there was no benefit to Impella. But again, those were very, very sick patients. Almost everybody had a cardiac arrest and almost everybody was intubated. And in that setting, they were too far gone for mechanical support. A large proportion of the deaths were because of neurologic, anoxic brain injury type of things. So which device, I think it's hard to say exactly this device for everybody. I think having a more organized early intervention, and in the NCSI, Impella was what was chosen as the device, did show that there was an improved survival to discharge. Again, it's a single arm registry study comparing to historical controls. So the true magnitude of the benefit and how much of it is from the Impella versus how much of it is from everything else, adequate volume resuscitation and quickly coming off of the vasopressors, for example, or escalating to biventricular support. So how much did each thing play a role? That's hard to tease out from that.
Okay, thanks very much for your insights. Yeah, Lapo, you can comment.
Oh, okay. Can I give a soft reminder on the use of IPP? I don't want to join the debate on IPP useful or not. But I want to remind one thing is stage E cardiogenic shock or essentially cardiac arrest. Remember, IPP, you need either ECG trigger or pressure trigger. In those cases, impending cardiac arrest, you need CPR at that moment. You won't have ECG trigger, you won't have pressure trigger. So for those stage E cardiogenic shock, never think about IPP. It will just hinder your work. And for Impella usage, be careful of RV failure. Impella, left side Impella, you won't have the RV failure. For ECMO, be careful of stroke. Actually, it's inevitable evil. In cardiac arrest, almost only ECMO can help, but it may kill you later. The patient, okay, you're not die on the table, but later, when the LV function, the cord will pump out and then you have stroke. And probably Impella will help most, but it's too expensive, I think, for most of the countries.
Okay, so the next question is also a very highly controversial topic. Is on the bifurcation lesions during primary angioplasty. I really have nightmare with these kind of cases. I always struggle between completeness of revascularization versus risk of stent thrombosis. So I hope to hear Sidney's experience being a very senior operator with expertise in all these complex lesions. How do you teach a fellow how to deal with a bifurcation lesion? Let's say a LAD diagonal bifurcation in the STEMI context.
Yes. Look, I think depending on the anatomical complexity, I think we always do provisional. We would definitely put a wire in. Anytime you think, I think it's in primary PCI, time is of the essence. You're kind of a little stressed. You just want to get things done quickly. So if you think the side branches we're protecting, you want it to be maintained, wire goes in. Shouldn't take too long. Sometimes it is difficult, but wire should go in your side branch, gives you access. You would, of course, establish flow in your major artery, like the LAD here, and then of course, either image or stent it, and then do as little as you need to the diagonal branch, I think. Rarely do you need to do a complicated two-stent strategies in the primary PCI setting. I think you're asking for trouble already when you're doing that. And remember, I didn't mention about a residual syntax score. Sometimes they're not very big diagonals, and you're spending a lot of time trying to ruin your result in the main branch. The main branch in bifurcations is the main branch in here. Establishing flow in the LAD is most important for the myocardial supply. And that little residual syntax, maybe only 3, or maybe a very tiny amount of myocardium you're trying to salvage with a side branch. So I think that's always situational differences. but I would err on being as simple and as quick as possible. Yeah, wiring side branches. Yeah.
How do you decide whether to deal with the diagonal or not? Do you based on TIMI flow, or will you consider even FFR, or just a visual estimation?
I think that you've seen the Korean data. A lot of times it's angiographic aberration that leads you astray. I would avoid even putting pressure wires down. If you've got good flows, I think you would leave it. Remember, there's lots of spasm around. Even if you have temporary closure of the side branch, some nitro sometimes helps it as well. So give it a bit of time. And if there's flow, I would leave it. I wouldn't try too hard. If you must, you can rewire through the stent and balloon it and do kissing dilatation. I would avoid putting stents through unless you really have to. You've got flow, leave it.
Wonderful, excellent. Can I hear Dr. Huang's experience in Taiwan? What's your practice in terms of bifurcation during STEMI contact, Dr. Huang?
Thank you. Thanks for your question. I think usually we still follow the single stent is better than bifurcation stent, especially in the primary PCI status. But if LAD orifice lesion or with 100 patient, so in this condition we will use a bifurcation stent. But usually, if the side branch less than 2.5, we will use a single stent. If we cannot see the flow after standing, we will rewinding to do the ballooning, or maybe we put the T stent if necessary.
But can I just follow up on that, Hui Chun? Is you mentioned that bare metal stent was the default stent in STEMI in Taiwan. So if you are doing two stent techniques, would you switch over to DES or you still stick with BMS?
Yeah, definitely. We will if bifurcation two stent, we will use DES. But in the penetration rate, actually in Taiwan may be different. In Taipei, maybe 80 to 20%, and in Kaohsiung maybe 50-50, depend on different area. So, but in this complicated region, layman or bifurcation region, we will suggest use DS instead of the BMS.
Lam Ho, very quick one.
Okay. Just try to search active transfer of part. I just learned from my friends in Queen Mary. They share a strategy called active transfer of part. You can Google it and then search this study. I try myself in those cases. It works. If you study angiogram and then you can simply keep one stem and then settle. Okay, that's the end.
Active transfer of plaque.
Yes.
We'll have to look at Arnab. Can I have the next question, please?
It's about the calcification.
I think it's on the issue of coronary calcification. And what's your approach? Okay, now we see a lot of this in Malaysia and we see a lot of this in Indonesia. Maybe Ashley, Dr. Taufik, and maybe Sidney can help out here.
Yeah, I'm very excited when it comes to rota. We do quite a lot. In fact, just yesterday I had a primary PCI in RCA, and it looked large, with a lot of thrombus burden. So we actually decided to put the usual wire down. Balloon had difficulty, but my IVUS didn't go in. So then my guys called me and said, hey, maybe we might need to rota. I said, go ahead, because the IVUS couldn't go in. It was a 3.5 vessel. So we went in with a 1.5 rota, and then the IVUS could go in and showed cracks, and we did a good job with two stents. There was always a worry in primary PCI with rota ablation, but we find that if it's calcified, you have no other choice. The only worry is if it's very thrombus laden. So if you can sometimes establish TIMI3 flow, what we have done before is give the patient thyrofibrine or integralin over 24 hours or 12 hours, come back the next day when his thrombus clear, then you can actually rota. But otherwise, if you have a nodule or uncrossable lesion, you have no choice. You have to rotablate, and I think they do tolerate well. And I personally done maybe almost 15 cases in primary PCI setting. Sometimes deferred over 24 hours. But if you have to, you have to. Yeah, thank you.
Yeah, Dr. Taufik, what's your experience in Jakarta?
Yes, if I mean the coronary calcification during I do in primary PCI, maybe I did with the non-compliant valve first, non-compliant balance, and then if cannot restore the atherosclerosis, we proceed to atherectomy with rota. But if the calcification is very long, maybe we did only with the EB. the DEP, and then optimal medical therapy, and then we prepare to tape it.
Okay, all right. Sidney, I know you would love to do rotor, but tell me, when would you not do rotor, but instead using scoring balloon, cutting balloon, or that's nonsense, you don't do that?
Shortwave.
I would start with, I know that in Asia Pacific, not everyone has imaging in the lab perhaps. And so the X-ray. So sometimes it is hard if you have bad X-ray lab. But if you put a balloon through the lesion, like in primary PCI, and do a stent boost, most people have that, or clear stent, you can see the calcium better. I think the more that you recognize that calcium is what's limiting you, maybe that's a good thing. I know that I totally agree. If the IVUS catheter doesn't go down, maybe it's an indication to do the rotor. So when would I do and don't? I mean, I don't mind doing rotor in a primary PCI. We have shockwave now, but imaging is great. But sometimes, in a primary PCI, NC balloon, get an NC balloon, see if it is actually dilatable. Particularly if you don't have much everything available in your lab, then that may be useful. And the X-ray clear stent, maybe stent boost, may be useful. And if you see that's modified, even without the imaging, maybe you can go ahead. Remember the old teaching in the United States, NC balloon dilatation, and check in a couple of views. If you can stretch a 3.0 NC balloon and it looks like it's inflated in multiple views, then a stent should get you that result. And so I think that is not a poor man's way, if you can't afford imaging, of getting you a good stent result. If it's not dilatable, you're in trouble. You need to do something more.
That's a fantastic advice. Thank you so much.
So any burning comments from our overseas experts? Or any questions that you...
Dr. Sidney, would you use CSI in this group of patients? Orbital arthrectomy?
We don't have CSI, so I claim no actual experience with CSI in any situation at the moment. Although I know that in a 6-range guide you can cut to 4.0, which is advantageous for very heavily calcified lesions. But I'm a bit worried about no reflow when you're having a lot of debris. So I don't know. Maybe you can tell me, and the Singapore and Hong Kong guys can tell me what is that like, and maybe it's not so great a device during a STEMI.
I do use CSI, but the debris is less. But the problem is, for me, it's very slow. You have to go really slowly and slowly and slowly. I find Rota, you can do it much faster. But I've not used CSI in primary setting. I suppose you can if you want to.
Perhaps Deepak and Lamho can comment. Yeah, maybe. Yeah.
We've gotten lithotripsy recently, so we like that.
And Nick, you were saying something?
No, I was just going to ask, do you still routinely use temporary pacing for all your RCA cases, or use aminophylline or just epiclin?
For rotor, is it?
Yeah, I mean, myself, I've actually stopped using it for the last maybe 5 or 6 years. And the trick is actually to keep your birth time short. So you give 5-10 second birth time. So by the time, rarely you go into bradycardia. And at the worst, sometimes I'll cheat with atropine. In fact, I give atropine upfront sometimes in RCA and circumflex, so cause tachycardia. So I have no need for temporary pacing for a long time.
Can I just have a very quick... Yeah. Can I just have a very quick show of hands? Sorry, go on.
If you have an impeller, you don't need it. You can uncouple the LV and you're fine. Number 2 is that if your patient's very unwell, unstable, very frail, I would put it in, although a balloon tip one, because there is a risk with a very frail patient that they'll crash when they have a heart block. But otherwise, I don't use it much at all. Yeah.
I think this is a great discussion. We really ought to allow more time for it, but we've been told that we overrun a lot now. So maybe it's time that I pass it back to Kaiwa to do the closing remarks.
Yeah, okay. I just have 2 very simple key messages to share to everyone. I think the first message is the primary PCI save lives. I think if there's the one procedure that is worth waking up at 3 a.m. in the morning, I think it's to do a primary PCI, because you know that you are making a big difference to patients' lives. And of course, all of us have done primary PCI for more than a decade, and some of us are feeling quite tired. But I think the adrenaline rush and the excitement certainly keep us feeling okay in the daytime. And of course, we have to depend on our coffee. And I think it's important for the younger generation of doctors to consider interventional cardiology as your career. And hopefully you guys also will one day take over from us. And I think with this COVID-19 pandemic, there's a lot of challenges for us. But I think despite the challenges, I think primary PCI should still be the mainstay therapy for our STEMI patients. And it's been a challenge to do primary PCI with N95. I think it's important that we all look out for each other and get ourselves vaccinated and keep our morale high and stay positive. So with these two closing key messages, I think it has been a great session this morning. I would like to thank my both co-chair, Paul, as well as Ronald, and all our overseas experts. Thank you for your great input. Very importantly is to thank our online participants who tune in on this Saturday morning. And special thanks to Biotronic for sponsoring this morning's session. And I would like to thank our APAC Secretariat, Christina and Yilin, for their hard work. And also Spring Forest Studio for the technical support. So with this, we'll have a good weekend, everyone, and stay safe. Thank you.
Thank you. Bye-bye.
Bye-bye.
Bye.